Really, truly an honor today to have Mark Wainberg as our speaker. He's currently the professor in the Microbiology Immunology department and the the director of the McGill University AIDS Center there. I think most of you know, and I follow Mark reading his papers primarily on reverse transcription inhibitors and resistance. And some of you know I work on integrase reverse transcriptase. We don't really cross. So I follow his literature, but never really have a chance to meet him until recently. My research kind of start looking at reverse transcriptase and integrase interaction. And Mark also realized how important integrase is and also started working on integrase. So I thought I met him a few years ago in a meeting. As I was talking to him, quickly realized of all these accomplishments that Mark obviously has achieved, more than 500 papers and being a giant in the field of transcriptase. What he really most proud of is actually his son in UCLA is an oncologist. So Seth, so I'm going to turn this to Seth, have him to come and tell us something more about our speaker today.
Okay, so thank you. And, Sam asked me to say a few words, so I think, needless to say, I'm not going to embellish about the career accomplishments of my father, who's the past president of the International AIDS Society, and also has received numerous awards, Order of Canada, Order of Quebec, some French honor that I can't remember offhand. I've been going to enough of these award ceremonies over the years that I just stopped going. It's too time consuming to go to every single award that he's received. But last week, also a very large award, as I understand it, at the infectious disease meeting, the Cubis Award.
Okay, enough.
But Sam asked me just to say just a few words of advice that my father gave me. So I'll briefly say I'm a medical oncologist here at UCLA. I do a lot of clinical trials in GI and phase 1 cancer in particular. So I don't really know anything about this field nor about this topic. My father gave me 2 pieces of advice. First thing he said is, which I remember to this day, and go get yourself an MD degree just in case research doesn't work out for you. And I've learned over the years that was a good piece of advice because I tried to do research and I realized very quickly I'm not nearly as smart as my father, so there's no way I could accomplish what he's accomplished in his career. So I'm happy I did that. I went to get an MD degree so I can always fall back on treating patients and doing clinical research, which is much easier, to be honest, than what all of you do for a living. And the second thing he said is, which is also telling, is don't go into HIV research because we're almost, hopefully, reaching the cure and we're reaching the end of AIDS research. And pretty soon, in 20 years, and this is 20 years ago, we'll be able to say that we've cured AIDS and go into something where we really need help, like cancer. And obviously, I see a lot of patients who have cancer, and I can tell you, unfortunately, we're nowhere near the accomplishments that they've had in AIDS. But his career has really been a good model for me to hope for, as a field in general, what has been accomplished in AIDS research that hopefully one day we'll get there in cancer research as well. So Thank you all for having me. Certainly I'm going to sit back and try to follow along as best I can.
Okay, thanks, Sam. I do think a career in research is fantastic, and I do think that hopefully we will bring HIV to a close, but it's important to have fallback plans. Part of my lab now works on dengue as a fallback, so but I don't know when we're going to have a cure for HIV, and certainly we all agree it's very important. And I want to point out that in this room there are people like Jerry Zach who are very important cogs in collaborations. One where I sit as an advisory member called the CARE Collaboratory, and hopefully over the next 5 years, one of these groups, including our own in Canada, which is headed up by a colleague named Eric Cohn, and I'm a member of that consortium. someone is going to make a difference. So I want to tell you what we're doing and hopefully convince you that we're also on the right track toward making a difference. So I have a disclosure slide. I just want to start out by saying that this guy was a great friend of mine. He was one of my successors as president of the International AIDS Society. His name is Hugh Blang, and unfortunately he was among the passengers on Malaysian Airways Flight 17 that was shot down by colleagues, I guess, of Vladimir Putin. So we've made, and I had another slide I meant to put in of another great friend from here who died not long ago, Charles Farthing. I'm sure some of you knew Charles, and I'm sorry I left that one out, but also a great guy. So here's a list of all the drugs that have been approved from the beginning of AZT going down the road up to dolutegravir. It's taken a long time, but it's been a great ride. And this slide just shows you how we've improved treatment responses. This is from my friend Julio Montana in Vancouver, British Columbia. But we used to have, good success about 65% of the time in terms of treating someone and getting them to undetectability. That means under 50 copies of viral RNA per ml of plasma. And now we're, getting up to the 80-something% range, which is great. And of course, after the introduction of the protease inhibitors in 1996, we reached a point where deaths plummeted in this country as these newer drugs got introduced, and that all makes sense. But this slide, and notice it's in French because I'm from Quebec. If I don't show you at least one slide in French, I can get arrested when I go home. So this slide shows 8 patients, all infected with baseline viruses that had all of these drug resistance mutations for nucleosides, non-nucleoside reverse transcriptase inhibitors, and protease inhibitors. And you know what? All of these patients died. We had no drugs to treat them with. They were absolutely bereft of hope. Imagine getting infected at baseline by sexual transmission with a virus that was already so multiply resistant to begin with. And fortunately, we no longer have these kinds of cases any longer. So that's history. All right, so now I want to just show you 3 or 4 slides that highlight the importance of viral fitness and why it's important to understand viral fitness assays. And this actually goes back to a clinical trial that gave rise to the approval of the newest member of the NNRTI class, non-nucleoside reverse transcriptase class, that is used in therapy, and that drug is called rilpivirine. And the reason the company, which was Janssen Pharmaceuticals, did the trial is that they said efavirenz is a very toxic drug, and they were right. We need a new drug in the NNRTI class to replace efavirenz. Let's develop this drug and let's do the trials. And they did, and it was a head-to-head comparison of efavirenz plus 2 nucleosides, which were mostly Truvada, tenofovir FTC, head-to-head against 2 nucleosides plus efavirenz, so rilpivirine against efavirenz. And you can see they were right. If you look at the adverse event profile, there were many more adverse events in the efavirenz arm than in the rilpivirine arm. But they got a rude surprise. Some of you who follow this stuff clinically will know this. And that surprise was that in people with high viral loads at baseline, efavirenz, the yellow bar, beat the new drug rilpivirine. How could this be? Anyway, then they, of course, did a resistance analysis, and they found out that somehow in the efavirenz arm, they had the old mutations, K103N. That's the signature mutation for efavirenz. But in the rilpivirine arm of the study, there was a new mutation at position E138K that no one had ever seen before, Where did this come from, E138K? And of course, for the FTC, there was the old standby mutation that we have known about for 30 years, 184V and 184I. Actually, I don't want to brag, but I'm not so young anymore. 184V was discovered in my lab. And there was a 184I mutation associated with rilpivirine. So we wanted to understand this, and we did this work, and it's been published. And what we did was make recombinant viruses. And one virus we made only had 184I. One other virus only had 184V. One other virus only had E138K. And each of these three viruses you see here had a negative impact on viral fitness. But when we combined the 138K mutation, which is the NNRTI mutation, right? It's a mutation associated with a non-nucleoside drug, together with either the 184I or 184V mutation, that is the nucleoside mutation, also in reverse transcriptase. Look at that. Viral replication was completely restored to wild type. And this was published, but it was the first time that anyone had ever shown that you can actually have compensatory mutagenesis involving mutations associated with two different classes of drugs. So we were quite happy with the story. What's my message to you? Viral replication fitness is very important. If you wind up impairing replication fitness, that has to be a good thing. But this is a virus that can very often compensate, as you see here, and when you have compensatory mutagenesis that restores viral fitness, that's not a good thing. Does that make sense? Good. Okay. So what's the proper definition, by the way, of genetic barrier for resistance? I mean, is it the number of mutations you need to get minimal resistance, or resistance more than tenfold, or time to development of clinically relevant resistance, or duration of exposure to drug in order for resistance to occur, or number of viral replicative cycles required to overcome inhibition by a drug, or is it all of the above? Multiple choice question, okay? And I just want to point out, resistance is complicated, okay? Nevirapine, you only have a single mutation that can give you more than 100-fold resistance. The same with efavirenz. The same with 3TC and FTC. But here's tenofovir, okay, which is a great drug. Tenofovir has been the mainstay of HIV therapeutics for the last 10 years. And all you need is one mutation, also discovered in our lab. I don't want to brag too much. And all you get is threefold resistance. But that threefold resistance seems to be clinically meaningful. And abacavir, the same. Darunavir, our best protease inhibitor, maybe you need more than 10 mutations to get very low resistance, relatively speaking, only 5 to 20, and about the same with the other protease inhibitors. And in general, you know, single dose nevirapine can give resistance very quickly. Triple therapy usually completely gets rid of the problem, except maybe when patients are non-adherent. And with the PIs, we know we have to be aware of mutations that are outside the protease open reading frame, such as GAG cleavage site mutations, which we don't very often monitor. But usually, what the compensatory mutations will do is to restore fitness. And the most recent important example of this has been not only with Stavudine, that was the earliest example where it definitely applied, but more recently, raltegravir, which is a great drug. Raltegravir was our first integrase inhibitor. And usually, the first mutation that you get is at position 148. And that mutation will give you a minimal level of resistance, but it will also diminish fitness. And then you get a second mutation at position 140. And the second mutation is compensatory, and viral replication is restored. At the same time, that resistance levels go up. Okay, so that's the paradigm for understanding HIV drug resistance in a general sense. I hope that's clear, okay? Usually the compensatory mutation restores fitness while at the same time adding considerably to the overall level of HIV drug resistance. So I'll skip this slide. And now let me talk about the new era of integrase inhibitors that in fact are potent and very well tolerated drugs. So before I show you our basic science stuff, I just want to quickly review with you the clinical trial data in regard to dolutegravir, which is the newest member approved drug in the HIV armamentarium of antiviral compounds, and it, of course, is an integrase inhibitor. So the first trial that was done was called Spring 2. Spring 2 was a head-to-head comparison of dolutegravir plus 2 nucleosides against raltegravir plus 2 nucleosides. And here you can see the trial results. This was what's called a non-inferiority trial. And notice at 48 weeks and 96 weeks, in fact, there's no difference between the arms. Both are great drugs. Raltegravir, or Icentris as it's called, is really a terrific drug, and I don't want to say anything negative about it because it really is good. Okay, then came the single study. Nothing is wrong with raltegravir, it's just that dolutegravir is better, as I'll show you. Then came the single study, which again plotted dolutegravir plus, in this case, a double nucleoside combination of abacavir 3-TC against a tripla, which is the mainstay of therapy, a tripla being co-formulated efavirenz together with tenofovir and FTC. And now there was a big shock. The dolutegravir arm beat the efavirenz arm, even though the 2 nucleosides with which dolutegravir had been combined, notably abacavir 3-TC, according to most people, is an inferior nucleoside combination than that which was used in a tripla, which was FTC tenofovir. Okay, so I want to underline that point. This was a superior result that was obtained in a non-inferiority trial, which my statistician friends tell me is important. And then there was a third trial done called Flamingo. This time the comparison was dolutegravir plus 2 nucleosides against our best protease inhibitor. Our best protease inhibitor is boosted darunavir. And again, the same thing. The dolutegravir beat our best protease inhibitor. So how do you explain this? How is it that dolutegravir seems to be outperforming every other drug? So let me just go through with you the mutations that have been seen when each of these 3 integrase inhibitors have been used in first-line therapeutic regimens. Okay, so if you start with raltegravir, you can have mutations in integrase at positions 143, 155, or 148, with 148 being the most common. These are primary mutations, and as I said, this first mutation gives you a minimal level of resistance accompanied by a loss in replication fitness. And then you get secondary mutations that can exist at multiple positions within integrase that serve as compensatory mutations to increase levels of resistance and at the same time restore viral fitness. And the same is true for elvitegravir. Here you can see different mutations in some cases, but the same principle applies. And so far, for dolutegravir, no mutations when this drug is used in first-line therapy. Not a single mutation so far. And that is unprecedented. So, here is a list of all of these various mutations that we know about that are associated with resistance against the integrase inhibitor family of drugs. And these drugs, by the way, act, as Sam knows very well, as integrase strand transfer inhibitors. That is the enzymatic step that is blocked by the inhibitors, whether it be raltegravir, elvitegravir, or dolutegravir. And here are all of these different mutations. And I show you the level of resistance in terms of fold resistance. In other words, the ratio of the IC50s of the mutated virus that has this mutation versus wild-type virus. And you can see some of these mutational combinations literally will knock out raltegravir. It will no longer be clinically active. In many cases, they also knock out elvitegravir, and there's consensus raltegravir and elvitegravir have completely overlapping resistance profiles, and you cannot ever use one of these drugs to salvage the other. And then here's dolutegravir. And you can see here the single mutations really don't touch dolutegravir. But when you have combinations, they do touch dolutegravir. They can render dolutegravir ineffective. So let me now make a very important distinction. This is what happens if a patient started on raltegravir and developed raltegravir mutations, and yes, if those mutations accumulate, then dolutegravir can be severely compromised. But if you start with dolutegravir in first line, in a patient who has never before been treated with an integrase inhibitor, then the mutational profile of dolutegravir is 0. Okay, so everyone understands that distinction? You can interrupt me, by the way, I think, if you need to, for questions, whatever. So consistent with what I just said, the company, which is Glaxo and Vive Healthcare, did a study, a clinical trial, called Viking, in which they took these people who had failed raltegravir or elvitegravir, who had mutations associated with raltegravir and elvitegravir, and they said, is dolutegravir going to work? And the answer is yes, some of the time. So it worked in 63% of patients, but that tells you that there were 37% that failed. And the reason they failed was because of what I just talked about, which is cross-resistance. Okay, then they did another study called the Sailing Study. The Sailing Study is a study in which dolutegravir was shown to be superior this time to raltegravir in treatment-experienced patients who had failed many drugs, but this time they had never, ever taken an integrase inhibitor. So they were taking an integrase inhibitor for the first time. In the Viking study, they had previously failed integrase inhibitors. Here, they're taking an integrase inhibitor for the first time ever. Paul knows all this stuff backwards. So, in 2 of the patients, they actually selected out a mutation in integrase at position R263K. Now, these 2 patients are doing well. In order to do a genotype, right, you've got to go, when you rebound, you've got to go above 400 copies per ml. Otherwise, the patient cannot easily be genotyped. So they rebounded to just above 400. They didn't get to 1,000, and they're doing fine, by the way. They have plateaued at about 400 copies per ml. So what's going on? Well, I was actually quite happy that these patients had developed this mutation, because a year prior, we had actually published on this same mutation that we had shown is selected in tissue culture by dolutegravir. So we found it first, and then this clinical trial came along and validated our tissue culture observations. And here is the clinical result. You can see the better result for the dolutegravir arm after 24 weeks, sustained, by the way, at 48 weeks. And now I want to show you this disclaimer. Why am I showing this to you? Because these companies all have lawyers that get extremely agitated if anybody ever suggests that somebody is trying to sell their drug off-label. And in fact, the company that this applies to more than any other company in the world is now Glaxo, which owns ViiV. And ViiV, in turn, owns dolutegravir, which now goes by the brand name of Tivicay. So the disclaimer is that this is our hypothesis generated by my group and is not necessarily subscribed to or opposed by the company. That takes no credit for this hypothesis. The point, of course, being they never want to be accused of selling drug off-label because they were accused successfully by the FDA of selling other drugs off-label over the past year, and the FDA fined them only $6 billion. Their stock took a hit, and they don't want that to happen again. Okay, that has nothing to do with this talk. But I show it to you. All right, so now subtype B viruses. We selected not just one mutation that I told you about at position 263K, but we selected a second mutation also at position H51Y. And using a subtype C virus, we found a different first mutation at position G118R, also sometimes 263K, and again the same secondary mutation at H51Y. So what's going on? So the level of resistance that 263K confers against dolutegravir, which actually selected for this mutation in the first place, so everybody understands why you get resistance, right? The virus is always multiplying and always mutating every time it replicates. So this mutation, like every other point mutation, pre-exists before anybody ever starts therapy or before we ever start our tissue culture selection. The mutation is there, and then all the drug does is amplify out a mutation that confers resistance against it. Everybody understands that, right? So the level of resistance was very low, 2.5 to 6-fold, probably not enough to really affect the antiviral efficacy of the drug too much. And by the way, I need to point out that this drug is also unique if you compare it with both raltegravir and elvitegravir in terms of its ability to durably bind to the integrase enzyme. So these are biochemical experiments, not performed by us, but performed at ViiV Healthcare by a very nice group headed up by Kendra Hightower. And you can see here the binding half-life in terms of dissociation kinetics for dolutegravir is 71 hours. That's pretty remarkable. Only 9 hours for raltegravir and only about 3 hours for elvitegravir. So right away you see maybe this is really a qualitatively different drug. And then and maybe that's one of the reasons that this mutation gets selected at position 263. And by the way, it was tough to select for this mutation. It must have taken us at least 6 or 8 months of constantly trying and working and feeding the cultures to select out this mutation over that long period of time. And sure enough, and consistent with everything that I've said and everything you know about, if you do an integrase strand transfer assay using recombinant integrase enzyme, you find that this mutation gives you a lesser level of integrase enzymatic activity than you find with wild type. So at the top here you have wild type, and here's your mutated integrase. Fair enough. However, here's what came next. We made enzymes that contained both mutations. And now what we showed was that when both mutations are present simultaneously, instead of there being a compensatory effect with regard to replication fitness, instead the enzymatic fitness was further reduced to perhaps a level of only 20% or 10% of wild type. And that was shown both in an integrase strand transfer assay and in a different assay that Sam Chow knows all about called 3' synthetase, or 3' processing. So here, the second mutation also adds indeed to the level of resistance. It went up to about 7-fold, still very low, comparably speaking. But enzymatic fitness went way down, and more importantly, replication went way down. So, as I say, this is unprecedented and leads us to our hypothesis, which I don't want to be dogmatic about, but quite simply is the following. The reason no one has ever seen resistance against dolutegravir in any of the clinical trials that have been performed until now is because the viruses that dolutegravir might select out as being minimally resistant are at the same time so unfit that they cannot grow, and consequently we don't see them when we do assays that determine whether or not a drug-resistant virus is present or not. So I presented this hypothesis for the first time, more or less, at this conference that I think Jerry Zak went to in Miami last December. And one after the other, some of my good friends, like John Mellors and Dan Koritzkis and John Coffin, took the microphone and more or less said, "Mark, you're full of beans." I don't know what word they used. Well, they were at a microphone. Yeah, it was probably beans. And they said, the reason no one has developed resistance against dolutegravir is because it has a high genetic barrier for resistance, which I certainly won't quibble with, but also because dolutegravir has only been studied in the context of randomized controlled clinical trials in which patients are very commonly highly motivated to be adherent to therapy. But just wait until this drug gets out there in the real world, and then you're going to see that there's going to be resistance. And I said that's a perfectly reasonable argument. But you know what? This drug was approved in the United States in July of 2013. So here we are now, 14 months down the road, and there is still not a single case of anybody having resistance against dolutegravir, even in the context of ordinary clinical usage in this country, which Tom Coates will probably tell you is not exactly the world's most antiretroviral therapy adherent country in the world. Is that a fair statement, Tom?
I think so. Yeah, I think so.
So that's my point. So yes, I'm perfectly prepared to wait. And I'll tell you, I had a bet with Dan Koritzkis and those other guys. John Miller said to me, "Mark, I'll bet you a bottle of Canadian beer that you're wrong." And I said to him, "I'll raise your bet. I call your bet and raise you to a bottle of $600 25-year-old single malt Macallan Scotch." And I said to Dan Koritzkis, "When are you going to pay up the bet?" I saw him the other day at ICAC. I said, "When are you going to pay up the bet?" He said, "I think it should take 5 years." So anyway, we'll see. I'm happy to wait.
But no bet with John Coffin? Because John Coffin in meetings has gone to the microphone repeatedly and said, any decent antiretroviral has to generate resistance.
And this does.
But-
This does. The proof of pudding is, of course, we have the 263K mutation is selected by this drug. The difference is that fitness goes down. And the question, therefore, is why? Why is this, so far at least, a unique situation clinically where no one has ever developed clinical resistance against this compound in first line? And what is the scientific explanation for what is going on? And I don't want to tell you I have all the answers. And in discussions with Sam, I'm perfectly agreeable to the idea that the mutations that we have identified could result in an integrase that is impaired in regard to participating in viral assembly because of interactions with capsid or other types of interactions that have been very well described. And I certainly think that's something that we could pursue, perhaps collaboratively. But the point is, we're talking about a situation that is so far unprecedented. So let me just go on in the minutes that remain and tell you that, of course, if we use a virus that has either of these mutations alone, 51 or 263, and we throw in just 3TC, we can select for the 3TC mutations, 184V and 184I. But when we have these doubly mutated viruses, we cannot select for resistance against 3TC. And by the way, something that I should have said but didn't. You know those clinical trials that I showed you? Not only, and I don't want to sound like an evangelist. Thanks, Paul. Not only did the patients never select out resistance against dolutegravir, neither did they have any resistance against the drugs that were used together with the dolutegravir in the same treatment regimen. So no 3TC resistance, no resistance, as the case may be, to FTC or tenofovir or abacavir. Again, so I'm just trying to put forward a hypothesis that is consistent with all of the clinical data and all of the experimental data. Okay, so in our hypothesis, if you get the 263K mutation, you now are at an evolutionary dead end. And that's the key. As opposed to starting therapy with raltegravir or elvitegravir and winding up with a situation now where these mutations confer resistance not only against those two drugs, but against dolutegravir as well. So I'm not an X-ray crystallographer. I have a few students who really understand X-ray structures better than I do. And they have modeled this, and they say that absolutely the crystal structure of integrase is such that you would predict that 263 together with 51 should have the joint effect of effectively freezing this molecule and preventing further adaptation by way of compensatory mutagenesis. What can I say? We'll wait and see. But certainly, and this is important, we haven't stopped. We've continued in the lab to try to find a compensatory mutation. And we're out to more than 4 years now. We still don't have one. So, what about the reason? Okay, if the raltegravir mutations confer resistance against dolutegravir, and I showed you they do, then how can we at least try to further understand this dynamic? So let's say we take the 263K containing virus and we select with elvitegravir or with raltegravir. Fair enough? So if we select with elvitegravir, in fact, you wind up getting additional mutations because R263K has also been seen more recently in a few of the clinical trials that were done by Gilead in which people failed on an elvitegravir-containing regimen. So this mutation can coexist with these other mutations, even though this mutation, if you start with dolutegravir in first line, may represent a dead end. And then if we start doing selections with raltegravir, and we go out to 30 weeks, there was no mutation. And then at 38 weeks, there were all of a sudden, there were these three mutations associated with resistance to raltegravir. But guess what? The 263K mutation disappeared because 263K doesn't seem to be able to coexist with the raltegravir mutations. So what happened here? Well, probably the 263K back mutated, reverted to wild type, and then the raltegravir selected out the classic raltegravir mutations. And here sort of is the proof. So we've made recombinant viruses containing these various mutations. And if you only have single mutations, the level of fitness is about 75% of wild type. With 263K, it's about 70%. The 140 and 148 mutations, as I told you, restore fitness back up to 95%. 263K with 138 gives you a level of fitness of about 25%. And then 263K with the raltegravir mutations really seems to kill the virus completely. So maybe now you're getting why I am excited about this. So yeah, my friends tell me, Mark, clinical resistance has occurred in regard to every HIV drug developed until now, as John Coffin says, and therefore must continue to occur for all future medications as well. And my answer to that, not to compare John to a horse, is no one wants to be the equivalent of a horse with blinders on, okay? We want to be scientists. Think outside the box. Think in as broad terms as you possibly can. And that's why my friend Francois Raffi and I wrote this paper last year called, which is the same as the title of this talk, What if HIV were unable to develop resistance against a new therapeutic agent? So, there's a lot of effort on cure now. Could this drug be part of this kind of strategy? I don't know. I mean, I'm intrigued also by concepts of histone deacetylase and farnesyl transferase inhibitors and antibody and immunological approaches and other approaches that are all part of cure strategies. And one of my former, and David Margolis, of course, who's a good friend, has been an important part of a lot of this kind of work. And one of my former grad students, I'm always proud of my former students when they do well. So James Whitney, who got his Ph.D. in my lab, just had this nice paper with Dan Baruch in Nature showing that in the SIV model, the reservoirs, latency reservoirs could get seeded as early as about 48 hours after initial infection. Just amazing, and kind of showing us how high the barrier is that we need to overcome in regard to this problem. But let's assume, just for a sec, okay, that our hypothesis is not completely hogwash. Then at the very least, right, a drug that doesn't easily select for drug resistance, logically, should be way more intolerant of ongoing transmission as long as patients remain adherent to therapy. And therefore, for me, this is the drug that we should be using in PrEP strategies. This is the drug that we should be using in treatment as prevention strategies, because really one of the concerns in all of those kinds of approaches is what's going to happen if we get drug resistance. So let me tell you, if our hypothesis is wrong, let's make it very clear. It might be. Time will tell. The company is still going to have the best drug in the world. Is that clear? Because there's no other drug that has given, until now, this profile of non-resistance in all of the clinical trials that have been done, and 14 months of open label usage. So I want to end by thanking our granting agencies and acknowledge the people in our group who have done this work, and especially Thibault Misbled, who's a great guy and working very hard, and Caitlin Anstedt, who is going to come to Sam's Integrase conference in Asilomar in just a couple of weeks. And that's it. Thanks for your attention.
Well, thanks very much for your talk. We're open for questions. Paul?
You know, it seems like we've gotten in trouble in our thinking because of the way that antivirals have developed. We started off with nucleoside analogs because they were being used to treat cancer and herpes, and when HIV infection came along, we dove into those and found all the problems with them. So maybe to an extent, it's just that we're used to the concept of failure, when in contrast, if we had found it easier to begin with protease and with, more importantly, with integrase, we wouldn't have such low expectations. So you came to a point right at the end that I think is a very interesting one. I wonder if Tom has heard discussion about this notion as well, that perhaps really for PrEP therapy, something like using RT inhibitors, Truvada, while it has been shown to be quite effective as a preventative strategy, asks for resistance, and that we've been doing it all wrong. I wonder if you've had discussions, either of you, heard of discussions of the idea of actually doing a clinical trial based on dolutegravir as a once-daily dosing prevention.
So look, the company, Vive Healthcare, that, as I told you, has distanced itself from the hypothesis. I think they're a bit stymied. They don't quite know what to make of it, to tell you the truth. And they don't want to be accused of selling drug off-label, as I mentioned. But, then, they want to sell their drug, right? They don't necessarily want to get stampeded quickly by guys like Tom into this being the drug that everybody wants to use in a prevention strategy. I would say this is by far the most sensible drug to use in a prevention strategy. But again, I don't want to be dogmatic about it.
Well, I think, sort of to put it a different way, I think the PrEP trials, whether by pill or by gel, show the promise but not the potential. I don't think anyone can think of these as final strategies at all. They're beginning strategies. And so that would, I think, argue in the same direction that Mark does. They're the first drugs that seem reasonable to try in this format, but they're far from perfect.
The problem that's been raised, Tony Fauci's editorial last year in New England Journal brought out that we need all of these things in order to move towards elimination of HIV and AIDS. We need a vaccine as a tool. We need preventative strategies like treatment of discordant couples to prevent heterosexual transmission. And the biggest PrEP therapy, preemptive therapy, works, but the problem in the trials was that failure was heavily linked to adherence, and that led to resistance. And so it does. Your talk and the paper that you cited at the end really made me wonder if it isn't time to get off the mark and do a second trial similar to the Truvada trial, in really looking at this as a better way to use that tool while we're trying to make all the other tools better.
And within the HIV Prevention Trials Network that I work in, yes, those kinds of trials are being planned, looking at pharmacokinetics as well as the design of clinical trials, because again, it'll have to be a head-to-head comparison now between them.
Jerry?
So slightly switching, nice talk, slightly switching gears. Have reservoir levels been looked at in patients on these drugs? Because in theory, if they stop some persistent replication, you might drop reservoir levels.
Right. So, Jerry, that's a great question, and I'll tell you right now that that's one of the things we would like to do sooner than later, but I encourage everyone else to do it as well. We should be getting gut biopsies and looking at how much HIV is reservoired after taking a drug like dolutegravir versus other drugs. And So you've had an advantage over us. This drug has been available in the U.S., as I said, since July of 2013, and I don't know of anyone yet who has thought of doing this in this country. We just got dolutegravir approved in Canada about 3 months ago. So I actually have a meeting this Monday with some of our clinical collaborators in terms of looking at people who are going to be taking dolutegravir in first line as part of our primary infection cohort, and that's exactly the kind of question we want to start to ask.
The implications are large, because if you drop the reservoir a bit, you can delay rebound and leave off drug, it's part of silicon and some of the other clinical studies that are going on. So it is actually kind of cool stuff.
Absolutely. Sally.
That was a great talk. That's really interesting. Who decides what is going to be used as a first-line drug? Say in African countries, is that based on the WHO recommendations? If so, what do the WHO base?
Well, I think who decides what gets used in first line in the United States, is after you pass the hurdle of getting FDA approval. I guess it's what physicians are most convinced represents the best strategy, and how the various marketing forces, meaning the companies, compete with each other in terms of influencing the dynamics. So as I showed you, in 63% of cases, dolutegravir can be used at least over 24 to 48 weeks to salvage someone who has failed either raltegravir or elvitegravir. So of course, Merck and Gilead, are having their reps go out there and say, you can start with our drug, and then if you ever fail our drug, you can take their drug. Of course. I mean, that's what you do if you're a marketing company. But really, the choices, I think, in the long term are scientifically based, thank God, by, intelligent clinicians who, in the case of HIV disease, tend to have very smart patients, and the decisions are made jointly, I would say.
But in African countries, what the decisions are.
So in African countries, we're talking about a very different situation, unfortunately, and this drug is still not available in African countries. If you ask the company, they will tell you that they are very committed to making it available expeditiously, but I have not yet seen it happen anywhere in the developing world. I hope it does soon. And the bottom line is that if you go to a lot of developing countries, one of the worst drugs ever developed for therapy, called Stavudine or D4T, is still being used in many, many places. It's tragic. And that's a drug that will definitely select out the K65R mutation and cause lots of cross-resistance to almost every nucleoside, including tenofovir. So we're living still in two very different worlds when it comes to drug access and how we approach drug therapy.
Okay, with no further questions, let's thank Mark one more time.